density and a higher fracture risk. So like everything else in medicine, smoking is negatively associated with your bone mineral density, and we know that current smokers have a higher fracture risk than non-smokers, and ex-smokers improve but never reach the baseline of non-smokers. So vitamin D, we derive our vitamin D mainly from skin-forming vitamin D after being exposed to UV light, so namely the sun. And the time required in the sun is face and both arms exposed for 1/3 of the time required your skin to turn a little bit pink, and that's called the minimal erythema dose. And this works out to be approximately 5 to 10 minutes in January in Australia in fair-skinned people. Obviously, if you had a summer like we've had this year where it's been raining and cloudy, you need a lot more time. And given our current lifestyles and long work hours, we find that vitamin D deficiency is quite common, and we normally like to replace vitamin D to a target level of greater than or equal to 75 nanomoles per litre. So calcium intake, the recommended daily intake is 1,000 to 1,300 milligrams, which works out to be approximately 3 to 4 serves of dairy per day. Now we prefer if people can derive it mainly from their diet, and I'm sure that some of you have read in the papers about this query increased risk of heart attacks seen with calcium supplements. And this comes from 2 recent studies suggesting there was an increase in heart attack rates in people taking calcium supplements. Although it has to be noted, in those studies, a lot of people were taking 2,000 milligrams daily. And also, it was not seen, the increased risk was not seen when people were deriving their calcium from dietary sources. An Australian study by Prince showed that there was no increase in cardiovascular events. So I'm just reiterating what has gone through about how there's this 2 types of cells, the osteoblasts, which mainly lays down bone, talking to the cells that ultimately become osteoclasts that resorbs bone, and in a normal situation, we have resorption and formation occurring in a steady state in all areas of our bone. So whereas in osteoporosis, resorption tends to occur more than formation. And also when we come to thinking about prescribing a pharmacological therapy for each person, we think about their age, their gender, their risk of fracturing, and the PBS listing, because most of the agents you need to take for a certain period and cost can become an issue. The ease of medication adherence, because we know it works if we take it, but it doesn't work if you don't take it. In regards to the choices that we have, they fall into 3 main groups: hormone replacement therapy, anti-resorptives, and anabolic agents, so it's stimulating bone formation. So regardless of what treatment you're on, they all work out to be about, they reduce your vertebral fractures by up to 50%, and reducing your peripheral fractures, so non-vertebral fractures, in 15 to 40%, up to 15 to 40%. And some studies have shown that it may improve your survival rate post-fracture. So given in women that it's mainly estrogen deficiency post-menopause, that estrogen works very well to preserve bone mineral density, and there's a few options. So traditional hormone replacement therapy, and there is a small increased rate of clotting, but not more than women who take the oral contraceptive pill. And tibolone, otherwise known as Levil, is a synthetic steroid that acts like an estrogen in selective tissue, one being the bones. Doesn't have an increased risk in clotting, but in some studies there was a small increased risk of stroke in older people, so namely about 70 years and above. And raloxifene, otherwise known as Vista, as its name says there, it acts like an estrogen, and it works well as well to prevent vertebral fractures, but has no study for peripheral fractures. And in men who are testosterone deficient and have symptoms, testosterone replacement therapy has been shown to improve your bone mineral density. So bisphosphonates is a big group of agents that we have under the anti-resorptive agent. They work by inhibiting the osteoclasts, and it comes in 2 forms, the oral or the intravenous route. And with oral agent, there's 2 available in Australia, known as alendronate, which is better known as Fosamax, or residuronate, known as Actonel, and intravenous is zoledronic acid. So the main things that we consider when we're prescribing bisphosphonates is that it's really poorly absorbed orally, so up to maximum 1% if taken correctly on an empty stomach, half an hour to 1 hour before food and remaining upright after. So fortunately though, last year Actonel has come up with an enteric-coated version and that allows you to have it with breakfast. So a lot of patients are reporting that it's much easier to take. And reflux does occur given that if you have to take on an empty stomach, and that tends to be more in the generic forms of alendronate. And the other concern that we have a lot of people coming to us is this condition called osteonecrosis of the jaw, which is an infection in your jaw that tends to occur around the same time if you have some major dental work done. But the real risk of it is 1 in 10,000 to 1 in 100,000 people on bisphosphonate therapy at the doses that we use for osteoporosis. So the PBS indications is if you had a minimal trauma fracture of your age 70 and above and have a T-score, that's a score that's reported on your bone mineral density when you're measured of less than minus 2.5 for Fosamax and less than minus or equals to 3 for have a score of less than or equal to minus 1.5 because we understand that people fracture on steroids at a higher bone mineral density. Strontium ranelate, otherwise known as Protos, is an oral powdered form of strontium. It is taken 2 hours after your evening meal daily, after no further food from your evening meal. And the main things that we consider as side effects are the diarrhea and nausea, headache and rashes. It is rare, but you can get a thromboembolism, which is clots in and deep vein thrombosis. So we wouldn't use it in someone who has a history of it, and it's only approved for use in women. So denosumab, or Prolia, which is one of the newer agents that Peter briefly came to talk about, it's the fully humanized monoclonal antibody, so the rank ligand inhibitor that blocks by disrupting the signal, therefore osteoclast doesn't develop and therefore preventing resorption. It is only approved for use in women only currently by PDS for women with osteoporosis. Teriparatide, otherwise known as Fortea, is the only anabolic agent that we've got currently. It's recombinant human parathyroid hormone given on a daily basis as a little small injection in the tummy. And currently, it's only approved for use once in your lifetime for a period of 18 months if you meet all the 3 criteria where your T-score is less than minus 3. And you have had 2 minimal trauma fractures, and you've also had 1 year of therapy of the anti-resorptive therapy and had a fracture whilst on therapy. So I thought I'll just finish with this slide because it nicely shows that your fracture risk increases with age. Thank you.
The next presentation this morning is going to be given by Dr. Paul Baldock, and Paul's going to talk about a couple of projects that are going on in the lab at the moment that we think are particularly exciting and may well lead in the future to new approaches to thinking about how we might treat our bones. So, Paul.
Off the bat, I am not a clinical researcher. Thank God. So I don't treat people. I'm a basic researcher, and so I, as the title suggests, I try to increase our understanding of how bone works, how it goes wrong, and from that, try to find new ways that we might treat the problems that we find. So we all know this story. The more bone you've got, the better off you are. We all know that we lose bone with age. From 40 onwards, we lose 1% a year, and we all decline. So the more you get, the further away you'll be from some perceived fracture threshold. The lower you are when you start, the more consistently you may end up in that area. Your bone goes from this to this with age. We know that. There's one thing that most people don't know about bone. It is an absolutely unique organ throughout every tissue. It is the only organ that fundamentally can heal without a scar. If I broke my arm when I was a kid and you x-rayed me, you'd have no way of knowing. And that is, there's no other tissue that even gets close. Liver can regenerate a little bit, but you cut your skin, you can see the scar, it replaces it with a slightly different tissue. Bone is unique. It can fundamentally replace itself, because it does replace itself. You get a new skeleton about every 11 years. There are little cells that take bone off, little cells that put the bone back on, and so it replaces what's old and it regenerates your skeleton. So if we can harness that, we can turn back the clock of bone aging and bone disease. And bone is very unique amongst that. And so what we aim to do is find treatments that will send us back this way. Okay? And that's what I'll be talking about today. We have a lot of very effective and wonderful anti-resorptive drugs. The clinicians are very lucky to be able to have as many weapons in their arsenal for anti-resorptives as they have. They're very effective and they're very good. And at this stage, they are the mainstay of clinical treatment. They will stop this getting any worse, and that is a great thing, and they will reduce fractures by 50%, and that is wonderful. But what we're looking for is anabolic treatments. We want to take this and push it back that way, because bone can. Uniquely, bone can. And so osteoporosis, in my opinion, in a very bold statement, it can be cured for the vast majority of people. If we can get the bone going the other direction, we can put more bone mass on, we can work ourselves back up that decelerating, that aging decline, and osteoporosis can be cured. And I believe in my lifetime it fundamentally will be cured. I do not think my children will be worrying about osteoporotic fractures. I'm not even so sure that I will be if I make it long enough. But what we need to do is be able to find those anabolic treatments, and I'll be talking about that today. So we want anabolic agents capable of repairing the bone loss, not stopping it getting worse. We want to turn it the other way. And at the Garvan, we're pioneering that sort of work with a very novel mechanism that alters bone, and that is the brain. This is a cross-section of the brain. The region I'll be talking about is down the bottom here. This is an animal brain, not a human brain. And see these little 2 green dots here? That's all I'll be talking about. 2 tiny little places about this big, and I'll show you what they can do to control bone. They occur in a region called the hypothalamus. The hypothalamus is a very particular part of the brain. It's not for thinking, it's for listening. So this little region of the brain listens very carefully to what's going on in the rest of the body. It's like mission control. Through signals coming back through the blood, through signals coming back through nervous tissue, it has an idea of what's going on in your toes, your ears, and all the way through a huge array of receptors for a wide variety of signals. And it then responds. It responds by changing the actions of the pituitary, which is fundamental to all of your hormonal control. And that has been known for years and years, and the endocrinologists that some of you will see, it all is based upon our understanding of that region of the brain. What I've been looking at, and we've been looking at in the Garvan, is the nerves that come out of here. So the pituitary makes the hormones that flow in your blood, and we're also looking at what happens to the nerves. They come out through your spine and through your nervous system to your tissues. So 2 levels of communication, one through the hormones and one through the nerves, and that's what we're looking at. And we can tamper with these, because I'm a basic researcher and I can play with cells and I can play with mice. It's a lot easier and a lot faster to do. And so NPY, neuropeptide Y, that is the signal that I play with the most. It is expressed in that region of the hypothalamus and is fundamentally involved in responses to starvation. So there are 3 major ways that your environment will kill you. Starvation, you won't get enough to eat. Predation, something large will come along and eat you. And infection, something very small will come along and eat you, right? And evolution has evolved extremely powerful defences to all of that. And starvation is definitely one of them. There are huge responses that we can enact if we trigger starvation responses. And neuropeptide Y is a starvation response. If we increase neuropeptide Y in that little region of the brain where the green dot was, the mice just eat. They don't clean themselves. They don't walk around. They don't do anything else but eat and eat and eat. They can double their body weight in a matter of weeks, because that signal is telling them that they're starving and that they're about to die. Okay, and one of the other things that your body will do when it thinks it's starving, it won't waste any energy doing anything else that it doesn't require. One of these is bone formation, because if you're starving, you're very skinny, you're very light, you don't need a heavy skeleton, and bone formation is turned virtually off. These figures down the bottom, this is a cross-section of the long bone of a mouse, the femur, so it's a weight-bearing bone. This is the bone marrow in the middle, this is the outside of the bone, and these two green lines represent bone formation. It's just a drug we put in, and the time between the two drug applications is 7 days. So that's what they made, the gap between there, in a week. Okay? That's a normal animal, and this guy has MPY overexpressed in that tiny little bit of the brain. Nowhere else. It's completely normal everywhere else. But he thinks he's starving, so he doesn't waste any energy forming any bone, and look at the difference in the bone formation from the guy who thinks he's starving and the guy who's normal. And bear in mind, this guy's body weight is doubled, so the actual amount of loading the bone needs to do is greater, and it still shuts it off. And so we can make a 7-fold change in the amount of bone formation going on in the skeleton just by playing with these starvation signals. And that forms the fundamental basis of what we've been looking at. And of course, we can turn it the other way. Tell the animal it's fat. That's what you want. The animal, you get really big, you need a bigger skeleton. And so if we, instead of making MPY excessive, we take it away, we get more bone formation. So you can see this is a normal animal, and this is the knockout, and you can see that we've nearly doubled the amount of bone formation. Okay? So we can then fiddle with these starvation signals, but get these really quite spectacular responses in bone formation. Bone formation is the one we want to change. Bone resorption, the anti-resorptives are good, they stop it getting worse, but bone formation is the one that drives it back, the one that drives it back to us, the fountain of youth, if you like. And so what we've found is that there is a continuum between this. This is the level of MPY in the little brain. The little green dots I showed you before, when we go from very high levels to very low levels, it's like going from a starvation response to an obesity response. So as the animal thinks it's getting heavier, the bone formation increases, and look at the difference we can make between these guys. And of course it has a response in bone mass. So if we can steal these responses and use them, we can try and hijack this response for our own means. Here's a little example of what this looks like. So this is activating that obesity pathway, and this is just a control, and this is just an optical cross-section of the femur, the weight bearing. You can see it's getting slightly bigger. So bone mass goes up, bone formation goes through the roof. So this is the guy where it's normal, and this is the guy where we've activated this obesity signal. His body weight doesn't change, by the way, so we can just take the bits we want. And the important thing for me is that the strength goes up. There's no point putting on more bone if it doesn't actually make it stronger, because that's what it's all about. Bone mass is one thing, but osteoporosis is about fractures. So it has to be, we have to strengthen the skeleton, not just make it look all nice and young, but make it good and strong. And we can do that, right? This is fascinating. This occurred in a mouse in 3 weeks. So, and mice bone changed a lot faster, but these are very rapid and very powerful responses, because if you're starving, you need to respond very rapidly, and that's one of the things that we can take advantage of. It's a little bit tricky getting drugs to the brain. We don't really want to have to do that if we can avoid it. And Y1 is a receptor for this MPY, and we've found it on the osteoblasts. Osteoblasts are the cells that make bone. So the distance between those green lines, that distance is because the osteoblasts, the bone-forming cells, work harder. And we can hijack that because we've found that this MPY signals directly to the bone-forming cells. And if we take out the receptors, so we make them deaf to MPY, it's like making them think they're extremely obese, we get an increase in bone mass. These are little cross-sections of the femurs of mice. The kneecap would be down here, and this is the shaft of the bone would go up to the hip. And you can see it's easiest to see in this cancellous bone and the end of the long bones, the remarkable changes we can make just by turning down any starvation signals. That turns up an obesity signal. So this guy thinks he's really heavy, so he forms more bone. And we get a lovely increase in bone, and very rapid. And so we've been able to take what was quite a novel thought, that these energy components these starvation responses will be fundamental in other tissues and be able to steal them and use them for our own purposes. And just to show you, this is our first ever drug study. So this is an antagonist, so it basically blocks the action of that receptor. The one before was a genetic knockout where the gene was just gone. This is a drug, an oral drug. We make little, sweet little jellies for the mice and they love to eat them. It's got the drug in it. They're very happy. And you can see it's called Vivo 3304. And you can see again the increase in the black bone compared to the wild type. And this was, we treated them for a month. More bone formation, and particularly this periosteal means the outside of the bone. That's where you want it. It's mechanically, mathematically far more advantageous to get bone here on the outside because it makes it stronger. And we can see almost a doubling of the bone formation out there with a drug, with an oral drug, that we could just take. So this is very exciting stuff. It's not just pie in the sky fiddling with mice, but it actually is driving towards a potential therapy. Now I'll just jump to something a little bit different, and these are drugs that are far more further down the development pipeline, and they're very powerful anabolic agents that have come about from study of some very particular lineages. This is a person with Buchen Disease, and I looked at this picture the first time I saw it, and I thought this little skinny line around here was the guy's skull, and I thought, so what, right? But it's not. See this huge black shape here? That's the guy's skull. Right? Exactly. One of these guys fell 2 or 3 floors off the roof of his house, just bounced, got up, and they thought it was a bit odd. X-rayed him, and look at that. All right? So these people have a spectacular increase in the amount of bone formation that's going on. A spectacular increase. And of course, we've stolen that too. What's happening in these people is their bone thinks they're being loaded constantly. They think they've got an elephant on their shoulders. And so bone makes little signals. This is a cross-section of mouse bone. See the little dots? They're the little cells, osteocytes, that live in the bone. There's thousands and thousands of them. They really are the brains of bone and tell everything what to do. That's when it's not loaded, and when it's loaded, that signal, that little protein that they're making turns off. So bone is constantly repressed, and when it's loaded, the brakes are taken off and bone formation increases. And 2 things go down, one protein called sclerostin and one protein called DKK. So they are down when they're loaded, okay? And that decrease in loading has a little bit of effect in the skeleton. Have a look at these. So sclerostin, normal, and the brakes are taken off. Normal, and the brakes are taken off. Look at the changes in these. Massive changes. This is DKK1. This is some work by a woman who I'm very pleased to say that Peter has managed to attract to the Garvan. The only DKK1 knockout mouse in the world. Normal, half off, completely off. Look at the spectacular changes these things are capable of. If you can block these unloaded, so these guys all think they weigh 50 tons, and their bones respond, as they should. So this is a protein that you need to block. And drugs development is very much skewed towards antibodies these days. It's not so much chemicals. The majority of them now will be antibodies. So there's a protein, and the antibody sticks on it, and it can't signal anymore because it's covered in antibodies. This is some work from a sclerostin antibody. And see the little green line? So this is a normal bone. This is 5 milligrams at 25. So it's just an increasing dose. And look at the increase you get in the bone formation, the green, the distance and the extent of the green lines. And this is a cross-section of the femur. You can see how much more bone formation there is going on and how much bigger it is. So really quite spectacular and very interesting and in clinical development right now. Right? So very exciting prospect for not only having anti-resorptive therapy, but having these very powerful anabolic therapies that will push the skeleton back, and then can we maintain that with a bisphosphonate. Really exciting. So, just to summarise, I'm nearly on time, the existing therapies are very effective. We should not look down on anti-resorptives. They're wonderful drugs. It is dominated by anti-resorptives, but anabolic agents have the potential to turn back the clock, and there are very powerful ones being developed. The mechanomodulatory ones are currently in trials, and we also have some very novel ones based on the starvation responses. So I have to say the future looks quite bright. Thank you very much.
what we're going to hear now is from Professor John Eisman, who's going to tell us a little bit more about what he sees as going on the horizon at a more practical level, i.e. in the clinic. So, John.
Okay, thank you all very much. It's actually rather daunting to follow what I think have been an amazing set of talks. That have been really excellent. But I'm going to try and tell you about where I think things are in the sort of the near future between the things that we already have and the things that I believe we will have, and that I think will be very helpful. So just to reiterate that the issue of why fractures occur, it is a combination of a number of different things. It's a combination of how good your bones are, what sort of physical structure they have and geometry and their microarchitecture, all things that Jackie Center talked about, and bone turnover itself, which is also part of a very important aspect of bone. I think looking around the audience, there'll be quite a few people who remember playing fiddlesticks or pick-up sticks. Is that correct? Yeah. And you remember how, you take out one fiddlestick and it was all right, and another one it was all right. You took out too many and the whole thing collapsed. That's when you lost, okay? And the question with bone is that when it's being turned over, sometimes it takes a very small bit of bone to be removed by excessive bone turnover that leads to the problem. And part of the reason that the anti-resorptive drugs work as well as they do is they damp down that excessive removal of bone so that you don't get that last little bit of bone being removed. And we've already talked about this. And it's important to think where we are in this area. I've been working in osteoporosis now for approximately 40 years. If I'd put up this slide 40 years ago, and it's a slide of your bone density and over time and what happens and how your fracture risk goes up and your bone density goes down and how all these different drugs might be used, what I could have put on this slide was something that showed that as you got older, your fracture risk went up, and that was it. There was nothing else there. We didn't measure bone density, we didn't have the tools to do it, and we knew nothing about all of these other factors and all these other treatments that are available. So the situation, the environment has completely changed from the way it used to be. Now, it was mentioned that we do have some treatments which push bone formation, and Dr. Chen referred to those. We only have one currently available, and this is something called Teriparatide or Forteo. Actually, it's a very expensive drug. If you were to go and buy it, it would cost you probably somewhere about $8,000 to $10,000 for a year and a half of treatment. And that's, in Australia, we're not terribly good at paying for drugs. We don't mind paying actually for alternative treatments, but if they're a pharmaceutical, we expect they should be provided. So not too many people want to do that. And because it's expensive, our pharmaceutical benefits have said, all right, it's got to be used in very, very specific ways. You have to have at least 2 fractures, maybe more. You have to have had 1 fracture at least while you're on at least adequate treatment for a year. And you've got to get a bone density measurement which compares you to young people that say that you're 3 standard deviations below the average of young people, which is really quite a lot. And this is an injection under the skin. You do it once a day for 18 months. It's actually very easy to use. We do know that you can stimulate the bone, and Paul Baldock alluded to this, that if you have something that's anabolic that increases the bone, you either have to keep it on it, or once you've built the bone up, you've got to use something that keeps it there, because the body will still say, I know I thought I was overweight, but now I know I'm not, I'm going to lose it again. So you have to, if you're going to trick it to do more, then you have to maintain it. And the other problem with it, there's some minor problems with the injections that usually for most people are not an issue at all. There's one thing that gets some people concerned is that as part of the studies that they were doing this agent, they did studies in rats. And they started when these rats were basically newborn, as soon as they'd been weaned, and they treated them for the lifetime of the rat, which at this stage was, I think, something 5 to 7 years. with a dose in a rat that's sort of this big, roughly the same as would be given to a human. So it's a hugely high dose for a length of time that represents the whole lifespan of the rat. And in some of those, and there are issues about the actual model of the rat, etc., but in some of those they saw a form of a cancer in the bone. When this was first seen, the company pulled all the development of the drug. And that's why actually the data only goes out to 18 months, and that's why in most places in the world you're limited to using it for 18 months, because that's when the study stopped. There then was a lot of discussion in the US with the FDA and the company, blah, 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 and eventually they said, well, you know, people are not really that similar to rats. It was a huge dose, the whole lifetime of the rat. We're not sure that it's got any relevance in people. So they eventually did proceed with the drug. It has been used. It has been used widely around the world. To the best of my knowledge, there has been one report of a case of this sort of tumour occurring. But if you look at the expected incidence of this tumour in that number of people, it's actually less than you'd expect. So we don't think this is relevant at all. Nevertheless, it's a very expensive agent. And the question, of course, is where are the new agents coming? So there are new agents that are coming to look at a better job in reducing the amount of bone that's removed and on ones that might increase the formation. And both of these are going hand in hand at the same time. One of the interesting problems in bone is that when you reduce the amount of bone that's being formed, there is a signal which tells the cells that make bone to stop making it. Okay, you've removed it, you stop removing it, you don't need to replace it. And the question is, can there be agents that might remove the bone resorption, block it, but still allow bone formation to continue? And so there are a number of different agents that are ongoing. I'm not expecting you to read this list. This only came out a year ago, and one of the drugs that they were talking about as coming was denosumab, which is actually now already here. This is the one that was alluded to that blocks the bone resorption. Another one is here called osteonecrosis, which also interferes in how these bone-removing cells work. I won't go into the details of it, and there are a number of others which I'll talk about and touch on in a minute. But the most interesting ones at this stage is this one here, which blocks this protein that Paul was talking about that signals from the bone cells to tell other bone cells stop working. It's sort of like a union rep. And if you can inhibit it, you can get more work out of the bone. So this is an example of or a cartoon of what these bone-removing cells look like. So they need a whole lot of things to work for them to be able to do their job. And the one that we're interested in that I'll talk about, this is a denosumab, which actually stops the cells being formed. This one interferes with how they work. So the cells are formed, they can sit there, they can start to do their job, but they can't break down all the proteins in the bone to allow it to be removed. And that may well translate to some of the factors in the bone being released actually being able to stimulate more bone being formed. And just to show you, and really I'll ask you to look, on this side here of the slide, these are some of these things that we measure in blood that give us an idea of what's happening. I won't go into that now. But what this shows here with this particular treatment is that if you give this, and this is a tablet that's given whenever you like, with food, without food, once a week, you actually see this really nice increase in the amount of bone, and this is showing that if you stop the drug, the effect goes away. And this is both, if you look in the lumbar spine, in your lower back, or in your hip. And we measure these two regions of bone, firstly because clinically they're important, secondly because they're probably the only two parts of the skeleton where we don't have bones overlying bones so that you can measure more easily. But what we can see is this increase here. Now, I won't go into the details of it, but these increases are really quite a lot more than have been seen when we've used drugs that, like the other anti-resorptive drugs. So this is quite interesting, both that it's more, and secondly, what we normally see is, and it probably relates to this feedback that Paul was talking about, what you see is you get an increase and then it flattens out with most other treatments. Here, you're getting a continuing increase, which suggests that the bone formation is ongoing. Now, why that's interesting is that there was a very, very large study that started a few years ago looking at this drug in women with osteoporosis. It was not terribly severe osteoporosis because it's unreasonable actually to say to people, we're going to put you into a study and some of you will get treated and some of you will just get a sugar tablet. So you have to pick people where their risk is low. But this study was designed, it's probably one of the largest studies that's ever been done in osteoporosis. I was talking to somebody from the company yesterday. They said this study has cost them $1 billion, just this one study. And the idea was to look at hip fractures, using that as the end point, or the most critical end point. And they planned to do a study when 165 hip fractures approximately had been recorded. They've done that, and it's been recommended the study be closed because they have shown that the drug is safe, very well tolerated, and the efficacy has been demonstrated for hip fractures, for spine fractures, and for that big group that Jackie Center was talking about, the non-spine, non-hip fractures. The ones that occur, that really represent the bulk of the fractures that occur in the community. So this looks very exciting. We don't know the data yet. All we know, this comes from a statement that was made by the company. They're still continuing to look at the study to ensure that they can see what happens in terms of safety, which is, of course, a thing that we should all be concerned about. But this is very exciting. The other part of this story, which again Paul has described very beautifully, is the idea of blocking, sort of attacking something that blocks this stimulating pathway. The bone cells are stimulated by a number of different factors. There's an orchestra playing on the skeleton of stimulation, but there are also things that very specifically block it. And this antibody binds to this blocking agent. So this is now to try and release the capacity of the bone to form new bone. It's sort of like most of the time the bone is sitting there, it's like a motor going, you're revving the motor up, but most of the time you've got your foot jammed on the brake. The body keeps that under tight control, and the idea of this is, can you release that off the brake? And what this showed, and I'll just point this out to you, this is after just 3 months, so this is very rapid. You've got the same sort of increase in the amount of bone density here as would have occurred after about 2 years with most of the other treatments. This is an increase, a very large increase in the amount of bone, and really this is looking very exciting. Now, just before I do that, I just say that the company is so confident about this. They're doing something that's never been done in osteoporosis research before. They're doing what is called an active comparator study. So every other study that you will have heard us talk about, they'll have compared a new treatment basically with just making sure that your calcium and vitamin D are okay. For the first time in this study, and we're involved in it here in Australia at the Garvan, they are talking about using this drug compared with one of the anti-resortives, if you like, the gold standard. They are so confident, and I think with good reason, that they will be able to see a benefit of this approach over the standard treatment. I mention that because we're very keen, if you know anyone who is interested in being involved in these studies, I mention it because I think it's really exciting, but at the same time, if anyone is interested in being involved in these studies, if you mention it to the people upstairs at the desk, we have very strict entry criteria. At this stage, it's still only in women, the study, but it is looking to see if there is a benefit of this treatment, which looks incredibly exciting. Now, the other thing that is important about the way we need to think about bone is that the benefit that you get if you're treating somebody for osteoporosis really relates to what their risk is. So if your risk of having a fracture is not very high, you have to treat a lot of people to get any benefit. And in fact, that underlying risk is arguably the biggest part of determining how many people you treat. This is this term that's used, the number needed to treat to get a benefit. And what it shows you is that as the risk of a fracture goes up, the number of people you need to treat goes down dramatically. And so, as one of the other things that's very important for us is that we consider that in the future we will use these very strong predictors of risk as a guide to who should get treated and who should get what treatment, because every treatment you have has at least a potential for a side effect. I mean, if you have a headache and you take an aspirin, you can get indigestion. You can actually even bleed from your gut from some things like that. So every treatment we take does have a potential risk, and that's across the board. Incidentally, I consider that's entirely true with alternative therapies as well, except they don't actually ever have to look at it or record it. But, you know, so if we can identify the people who are at greatest risk, we can identify the people that we use for individual treatments. So where I see the future going is that osteoporosis will be recognised by both the medical and the lay community as what I refer to as a malign condition. It's not something benign that doesn't really matter. Jackie Center presented the data which talked about just the impact of one fracture on another fracture. She didn't present the data but alluded to the fact that it's actually very nasty. You are more likely to die than other people at your age if you've had a fragility fracture. And treatment, incidentally, may reduce that risk, which is very important. Peter Croucher talked about some of the genetics, and we've been involved in looking at the genetics all along here, and did some of the initial work demonstrating the very strong genetic effects. Identifying those genetic markers may also allow us, on the one hand, to identify people at increased risk, on the other hand, to actually identify new targets for treatment along the lines of the beautiful work that Paul Baldock's been doing. Incidentally, about 3/4 of your risk of an osteoporotic fracture is genetically determined. And I always say to people that, you know, my best advice to them, if you want to avoid osteoporosis, is choose your parents wisely. The work that we're doing in terms of the clinical parameters, the risk parameters that Jackie Center alluded to, allowing us to predict absolute risk, we're talking, I think, in the future that we'll be using the anti-resorptives for people with relatively mild osteoporosis and the anabolic agents followed by anti-resorptives for severe. And hopefully, as we go along, we'll be able to use some of the genetic tools to actually even pick the right treatment for the right person. Thank you very much.
Oral calcitonin, which she said it will hopefully go into production fairly soon. Given that this is not a new compound, just a new and improved delivery of this safer compound, could this be the answer? Now I wonder whether John or Jackie may want to address that to start us off.
Calcitonin has been around for a long time, and it was initially studied using a subcutaneous injection. It actually, for a variety of reasons, probably relating to how the body signals and recognises signals and tries to adjust to them, it actually doesn't seem that it's actually that effective in most of the studies that were done. There was one study which compared, I think, a dose of placebo injection, saying it was 200 units and saying it was 400 units. They didn't see any benefit with 400 units. They didn't see a benefit with none. And there seemed to be a benefit with 200. That's a very uncommon sort of biology to see. And so we're not really convinced that this is actually as effective as it was seen. And also, there have now just been reported some potential adverse effects with calcitonin, which is used for other situations. I'm trying to remember what it was now. It was some rather, it was nasal calcitonin, but it was some rather nasty side effect that nobody, some sort of tumours of some sort. Didn't make a lot of sense, but, you know, again, to suggest that this is somehow safer. I don't believe we've got good evidence.
Okay.
You're speaking about Actonol then?
No, this was calcitonin, oral calcitonin.
What do you know about Actonol?
So
I tell you what, if we
we've got the
come to the
microphone, so if you need to ask a question, just put your hand up and I'll come to you.
Obese people likely to have strong bones, given that osteoblasts and osteoclasts might be in good harmony with each other. Just because they're obese and heavier, would the bones be strong?
In general, yes, that's what we think, that their bones are strong. However, there have been a few recent studies suggesting that fractures do occur in obese people, and that maybe their bones, for a variety of reasons, including some of the neural signals that Paul talked about, that their bones may not be quite as strong as we think. We've got a lot to do to unravel this issue. But in general, the bigger you are, the stronger your bone mass and more bone mass. In those people who are super obese, it may not be quite the same relationship. And certainly there is evidence that fractures certainly occur in obese people as well as non-obese people. Possibly not as much. And certainly if you're very thin, you've got an increased risk of fracture. So there does seem to be a fairly linear relationship, but it's not quite clear at the top whether that relationship continues to be as linear as it is sort of more or less through life.
Okay, there's a question in the middle there.
Does Elizabeth Blackburn's work on perfect cell replication have an impact on your work?
Paul, do you want to consider that?
Okay. Anytime you have cells that need to divide and replicate themselves, there's a chance of an error. The longer you are, the longer you live, the more cell divisions you have, the more chance you have for an error. There are amazingly complicated systems that enable one cell to split into daughter cells and make a perfect copy, but it's not always perfect. And when there are imperfections, there is a chance for error and problems. The more time we have bones, the more cell divisions there are, the more chance there is for error. The higher the bone turnover, the more cellular requirements there are, the more chance there is for error. So wherever there's division, there is chance for error.
Perhaps I could just add to that. John talked about PTH, for example, and there's obviously been an example where this has been explored in animal model systems, and that possibly wasn't relevant to the clinical situation. Now, we don't have data yet to say that that's going to be an issue if we use these bone anabolic agents long term in people, but it's something we obviously have to consider. Where are we going next?
Dr. Chen, I wonder if you would elaborate on some of the matters that you discussed, namely the relationship of heart disease and listed stroke connected with calcium supplements such as caltrate, necrosis of the jaw, and long-term use of Fosamax and side effects of a cluster.
I think that's a lecture in itself, I suspect. So we'll all come back next week for that. Do you want to say a few words on that?
I'd really like to emphasise on the osteonecrosis of the jaw is very rare. As I've said, the incidence is very low, 1 in 10,000 to 1 in 100,000 people. And it tends to be seen if someone's having major dental work, so such as root implants or canal work. If it's at that stage, and if someone was due for another dose of the intravenous cluster, we would say wait till you have your dental work, and then for your healing to occur, then turn another dose of the intravenous cluster. And the side effects of the cluster mainly is it's very well tolerated, although in about 30% of people, for their first infusion, they could get like a flu-like illness where it cesses within 48 hours in those people, just with some paracetamol.
And does the jaw necrosis follow excessive use of Fosamax too, as well as a cluster?
So the risk is about the same for either Fosamax or a
how
cast.
often you use the Fosamax if you're having it?
Realistically, at oral doses, it doesn't make as much of a difference because actually the concentrations, realistically, after you have it orally, it's about the same. It's more about the storage of it in your bones after having the Fosamax. So whether you take the Fosamax or not every week doesn't really change the dose.
Just to add something to that, I think one of the issues about osteonecrosis of the jaw has really developed out of the treatment of people that have had cancers. So one of the areas that really this first came to light in was the area of multiple myeloma, which is an area we worked in. People that have multiple myeloma were given very high doses of IV bisphosphonates. And it was in that group of patients that this was first recognised. So in the osteoporosis setting, where you're receiving much, much lower doses and are often given very, very infrequently, the cumulative dose is very different. So I think what Weiwen is saying is that it's not necessarily quite the same as if you're in a different sort of clinical setting like that. Sorry, so I think we've got another question in the middle there.
Just for 1 second.
Sorry, John.
I guess one of the other points that I would like to comment on, when you've seen the reports in the literature about osteonecrosis of the jaw, they actually are the ones that have come out of the cancer area where the doses are huge. And what they did initially, when people didn't seem to have healing, they brought in a dental surgeon to try and scrape out the bone. And it's very clear that was never going to, in retrospect, it's very clear that was never going to help. But what you've seen reported is almost, to the best of my knowledge, without exception, the problems that occurred in people who have had cancer and have been on these very high doses. To qualify for having osteonecrosis of the jaw, if you've been on one of the bisphosphonates for osteoporosis, all you have to have is where you've had something in the mouth and the bone hasn't healed completely after something like 6 or 7 weeks. You may not have any pain, any other symptoms, but then it still makes the criterion. So I think this is something that has got very much concern and blown out of relevance compared to the risks of fractures for which people are being treated.
Okay, so there's a question in the middle.
Look, this question is a fairly specific one, so it doesn't have a long answer. Garvan syndrome and the hypothalamus we may know about, and I guess this is a question for Dr. Baldock. Of course, they're living longer and showing signs of osteoporosis and so on. So, because of the hypothalamus, I'm just interested to know if you consider that the research you're doing with anabolic building up and utilising those cells will ever work in people with Garvan syndrome.
It's interesting you should ask that. We have an active probability study going on right now. It's a very particular genetic mutation in a mouse, and we have seen that mutation is associated with markedly smaller bones and a number of the characteristics of Prader-Willi syndrome. Given that that's what we see is a reduction in the amount of bone formation, so the green lines were closer together in this particular model of Prader-Willi syndrome, and in that case, then anabolic treatment would be absolutely perfect for that. And so the model looks fabulous. It looks like it's a very complicated model, but it looks like it is showing quite a number of the key characteristics of Prader-Willi syndrome. It's really very exciting. It's an interesting question. Thank you.
So I think we've got time probably just for 1 or 2 quick questions. So there's one lady here in the front. Oh, sorry, the microphone's up there, and then we'll come to you in a second.
I may have misunderstood, but I'd just like to clarify that you are intending to do research with people who've already got very advanced osteoporosis and the risk of future fractures. I've had several crush fractures and given full day.
Yes, that's exactly
Well,
the area
yeah.
where people are.
When it will happen again, and it seems like it's no morning, and I wouldn't really happy to go on this, into
Well,
research.
there are very specific requirements, but please, if you leave your name with one of the ladies at the front desk,
Yeah, that's what I just wanted to clarify.
and we can contact you and find out how that goes.
Oh, thank you very much.
Okay, there's a lady down here in the middle. Just here. And then then we'll probably take one last question on the right-hand side.
Sort of general. Again, it's the same as...
Can you speak up a little bit?
Really close.
Better?
Yeah.
Similar question to a couple of the previous people. I'm having some dental work at the moment. I've had a tooth removed and getting ready for an implant. The dentist was very concerned because I've been on the trolley up for getting close to 2 years. He's doing it, and I'm going on Monday to have an X-rays done for the next stage to find out, because he said a lot of the bone had died back. He did say it was due to some infection that I had before he commenced. But he said the bone would grow back, whereas, well, he thinks it will, he's hoping it will. So what are your thoughts about that trolia that I'm on and having further dental work?
This is an easy area to talk at one level. This is actually not that much evidence, so I can pretty much say what I like, because we really don't know. So it's really very helpful. Basically, what we know is that, as you would expect, that infection is an important part of the problem of bone loss. Anyone who's got periodontal disease loses bone. It's very clear that happens. The advantage with Prolia is that, I don't know when your last injection was, but its effect wears off at about between 6 and 7 months. I can't count that fast, but you know, if there was a really big concern, what you can be comfortable about is that, you know, by September or early October, the effect would have worn off. So there was like you had never had it. So any concern you might have is really, or he might have, would be relatively minor. I might say that most of the concern about this is driven by medico-legal stuff, not by science. So the risk is still incredibly small. Jackie Centre and I and Dr. Chen have seen many people who have been on long-term bisphosphonates for years. They've had dental work, they've had dental surgery, they've had implants or whatever. They come back, they've had no problems. Many times people come back and they say, oh, I've had this done like between when I saw you last, everything was fine. I think this is something that's been wildly built up. It is an issue with people being treated for cancer, because there are issues as well. But I think
Okay, I think we've got probably time for one last question, I'm afraid, because it's now 12 o'clock, so last question.
Could I clarify, are you advising that people should stop taking bisphosphonates after X number of years? Because I was told you had to stop after 10 years.
No. I don't know of any condition in medicine where you treat people for a short period of time, except maybe an infection. If you've got diabetes, hypertension, whatever else chronic condition you might like to say, if you require treatment, you continue to need treatment. There has been a lot of discussion about people going on so-called drug holidays, but I think the evidence that that's necessary is very limited, and I think it's something that is again being wildly exaggerated compared to the actual evidence. It really relates to how good or bad your bones are. If your bones really indicate that you're still high risk of fracture, then you really need to have some ongoing treatment. I don't think you should be stopping.
Okay, well, thanks very much, everyone. And I'd just like to say a couple of words of thanks to everyone.